2 minutes. 2 minutes. Spurs ball. All right, ladies and gentlemen, if we can have your attention, please. I'm sorry? Oh, the cars, right. Wow. That never happens. Thank you. Silence. It's a good thing. My name is Ron Aaron. I'm delighted to be here as your moderator today. You may have joined us during the pandemic when I had the pleasure of moderating the GPA Live series of broadcasts that ran for 65 shows, and we had more than 131,000 people all over the world who tuned in and listened. We're delighted to be back here today live in person with the Symposium, and we are very, very pleased to have you with us. On each of your tables, you'll see some cards. If you have a question during a presentation, hold the card up when the presenter is over, and our two volunteers, they're like ball folks at a tennis match sitting over here, right? Hold the card up and they'll get them. Or if you'd like to voice a question, we have a microphone directly in the center over here, and you can go to that mic. And we ask you to do two things. Keep the question short. We're not looking for speeches. And if you've got a question that you think is not relevant to everybody here, wait till after the presentation and during the lunch hour, if you can find the presenter, put the question to them at that point so we can keep the program moving. A few housekeeping details. There is water on the shelves behind the question grabbers. Bathrooms are through that exit sign, both men and women, and you will find those without any difficulty. We'd like to thank our amazing sponsors whose names will be scrolling throughout the program on this screen. And without them, this program could not have happened. We'd also like to thank our major grantors, the folks at Valero and the Greehey Family Foundation. And again, check those sponsors out. And we're now going to introduce our first presenter. Delighted to have with us Dr. Christina Aguilar. Dr. Aguilar is a behavioral health consultant at the Center for Healthcare Services. She specializes in the area of mental health and chronic pain. As she said to me, she's a PCP, a primary care psychologist who works with PCPs, primary care providers. Dr. Aguilar holds a double appointment as adjunct faculty at Long Medical School at UT Health in the Department of Psychiatry and the Department of Community and Family Medicine. You will learn how neurobiology, our brain, is changed by the experience of chronic pain and the impact on mood and memory. And since Dr. Aguilar is our first speaker, I want to hear a great, big, huge welcome for Dr. Aguilar.
Thank you. Thank you so much, and good morning, everyone. It's been really nice to see everybody kind of pass by our table. Thank you so much for having me. I appreciate it. I'd like to jump right in. I know I'm on a time limit, and hopefully I don't go over time. So real quick, I've already had this little explanation to a lot of you who have come by the table. I represent the Center for Healthcare Services. We are the local mental health authority, and we provide substance use treatment for mental health disorders, typically bipolar disorders, major depressive disorder, or schizophrenia spectrum disorders. We're the third largest local mental health authority here in Texas, and most of the counties here in Texas have a sister agency like the center. We celebrated our 55-year anniversary a couple years ago, or in November 21, so we've been around for a long time. We have 5 operational divisions. We do have children's services. We get that question a lot. We primarily serve adults, though. We have a large community and crisis response team. We also provide services to individuals with developmental disabilities and have medical services, which I've been talking a lot about today, and we'll talk about a little bit more. So jumping right in, I wanted to try to talk a little bit about how our brains are changed by the experience of chronic pain and its impact on mood and memory. And hopefully you can take away some strategies or a few treatment recommendations if you're suffering from chronic pain. One of the things that I wanted everybody to kind of think about is chronic pain is a debilitating condition, and very much I like to kind of think about it a little bit like the weather. And so when I talk about, as a psychologist in integrated primary care, I talk to many of our patients for how to manage chronic pain. And it's a very difficult concept for a lot of folks because, of course, people want pain just to go away. And so what I try to tell people is, well, think about it like the weather. As you know, living here in South Texas, when it gets to 99 degrees, it's hot. And there are some factors that make the experience of that 99 degrees worse, and there's some factors that make it better. And so we do know, right, that when the humidity index is high, how does that 99 degrees feel? Like searing steam, right, on your skin. And we know, right, when the humidity level drops, 99 degrees is still very hot, but it's also a little bit more tolerable, and you might be okay if you're in the shade and if you do a few things, if you're dressing cool. And that's kind of the way to think about managing chronic pain, or what I guess a psychologist could do for chronic pain. I don't have the tools. I don't prescribe medicine. I don't have the tools to decrease the temperature, right, or the pain intensity. But I can help you do things to dehumidify the way the pain feels or your experience of pain. And so that's kind of the really important part about our day-to-day functioning and our quality of life. There are other factors to consider when we think about how we experience chronic pain. So we know that, one of the takeaways, of course, is that there is a very close relationship between mental health and our mood and chronic pain. They're very closely related. Oftentimes, pain is a signal that there is something wrong happening, especially acute pain. And so what we know and what we've studied about acute pain is that it's our warning system, and it triggers an alarm system in our bodies. So oftentimes, with people that have chronic pain have been managing this ongoing alarm system for a very long time. And so there tends to be, over time, this development of other sorts of responses to that alarm system constantly going off. And that can be things like hypervigilance. So you start to worry about the next time that alarm system goes really super high and is very super loud. We can start to mentally worry, ruminate, and think about the worst case scenario in our minds, which tends to enhance and magnify pain. And then we start to avoid things. We start to avoid the activities that we used to love. We start to avoid people because we're afraid people may not understand. We start to avoid people because we don't feel well. And then that actually creates a very vicious cycle that creates depression, can create anxiety. And it is a pretty difficult cycle to break without some kind of intervention. We know that it can be physically and emotionally stressful. We know that pain triggers that alarm system that I'm talking about in the brain. Part of what's happening is that there are chemicals that get released into your brain from the amygdala, from the hypothalamus, and we are trying to, your body is telling you there is something really wrong with what's happening from those pain signals. And so part of what we have to do is learn how to respond to our bodies. Our body is trying to tell us there's something wrong, and we have to learn how to respond to that. And when we learn how to respond to that, it actually helps our brain, and it helps retrain our brain and retrain our mind to be able to condition ourselves in a different, more healthy way. So sometimes our social connections are disrupted, our self-esteem is disrupted, but we have to be able to respond to that well in the face of that kind of adversity, which is very, very challenging. We also know that that kind of stress brought on by chronic pain creates low levels of serotonin, and we know that serotonin is something that's really needed for a stable mood and a sense of well-being. You can lose sense of who you are because of chronic pain. Self-esteem is a huge issue. Making sure that you get enough sleep and that you're staying socially connected is a really important piece of this. When we have a vulnerability in our genetic or family system to a mental illness or mental health condition, that's also very important to think about. We have to be sure that we are getting the treatment that we need in order to make sure that we don't fall prey to some of the mental health conditions that might be occurring in our family systems. So the other thing that I wanted to spend a little bit of time on is talking about memory. What we know is that chronic pain affects the brain and can affect our ability to think, our ability to concentrate, and we've done quite a few studies about the brain and the effects of chronic pain on memory. What we know is that there is a reduction of the gray matter in the prefrontal cortex, which I tried to highlight there. And our gray matter controls our memory. It influences how we learn. It helps us process information, how we form thoughts, and influences our attention span. Part of what we need to, be sure of is that the longer you are in chronic pain, the more gray matter you lose. However, there is hope, which we'll get to in a minute. Among the other things is that we know that the medial prefrontal cortex can create some problems with memory, long-term memory retrieval. So that's another key piece. When we are experiencing chronic pain, sometimes we might have trouble thinking, concentrating, remembering things. We also know that the amygdala, which is the part of the brain that helps us process emotions, is also highly activated during our pain episodes. And so there can be a real kind of a lot of background noise happening constantly. So it makes the pain processing, our brain is trying to focus on the pain processing while we're trying to focus on what we're going to say, all the things we have to do for the day. That's really one of the key pieces as well. We have also some issues in the hippocampus. The hippocampus helps us convert short-term memories to long-term memories. And what we know is that there is a decreased neurogenesis in the hippocampus because of chronic pain. And again, there is some hope related to that, but it is important to know that those are things happening in the brain's circuitry because of some of the issues with chronic pain. The disrupted equilibrium is really the way that your brain tries to balance its functions. So part of what starts to happen is that, like I was saying earlier, your emotional center is constantly trying to process pain signals, and it's a very noisy center. So it doesn't allow for clear thought or your ability to kind of operate in a sequenced manner, to plan things. That could also really be affected. So for fatigue and insomnia, obviously more problems with memory and concentration. A lot of folks with fibromyalgia tend to have a cognitive fog or something that's called fibrofog, and that's always very difficult as well. It's hard to focus, difficult for folks to remember. We also know that most folks that suffer from chronic pain may start or have used opioids. And we know that although that's a controversial issue, long-term use can also be associated with a decline in cognitive functioning and memory problems. So part of what we want to know is how can we help this? What can we do? One of the things, I have a whole list of things, a lot of different slides talking about very specific tasks about what we can do to manage chronic pain, to manage these brain changes. Part of what's really important, like I said, is how we respond to that alarm system that's constantly going off, creating those cascades of chemicals that is changing the volume of the gray matter in the brain, and that's changing the neuroanatomical structures. So what's interesting, and I guess like the dehumidifying effect that I wanted to talk about, sometimes is about a mindset shift or a mindset change. So these are kind of some of those things that might be related to that. Acceptance of pain experience is a key piece, although it's probably one of the most difficult pieces to accept. But it's kind of like accepting the temperature outside. We don't like that it's so hot every summer, but we do live here, and we find ways to manage it. And so that's part of what the mindset that actually really helps with chronic pain. So on these two different slides, we have this slide and then the next slide to kind of talk about all these very specific things: being grateful, reducing stress, finding distraction, find others who understand, feel comfortable asking for help. Really, what's very important to think about is that we have lots of different treatment strategies that are that combine all of these different practices. One of the most helpful kinds of treatments for chronic pain is CBT, or cognitive behavioral therapy for chronic pain. There's actually a lot of evidence-based treatment that that can be delivered to decrease pain. It's very effective. The other kind of treatment that is found to be very highly effective for chronic pain is acceptance and commitment therapy. It's a newer kind of psychotherapy, but it's also highly effective in working on that mindset. And it's highly effective not just for chronic pain, but also for other conditions as well. We know that chronic pain might often come with anxiety. We know that chronic pain also has a high correlation with post-traumatic stress disorder. We know that anxiety is part of the picture as well. So acceptance and commitment therapy is one of these treatments that is very helpful when working with chronic pain. One of the other kinds of treatments that's very helpful is mindfulness self-compassion. This is by two researchers. One of them is out of Austin, actually, Kristen Neff and Christopher Germer. They have a dual approach to this treatment. And so mindfulness is probably something everybody is familiar with, and meditation. Mindfulness asks the question, what am I experiencing? What is happening in the here and now? Whereas self-compassion is asking, what do I need? And so pairing those two things together in a meditative practice is highly effective in changing the brain structure. So part of those brain structural changes that I talked about can actually be regenerated because of neuroplasticity that the brain has. We can regenerate some of the volume that we lost by mindfulness and meditation practices using things like acceptance and commitment therapy or cognitive behavioral strategies. These are part of a few of the different techniques and strategies that are helpful for psychotherapy for chronic pain. I'm sure this crowd is fairly familiar with a lot of these stress reduction techniques and maybe even some pain rehabilitation programs. What I really want, I guess, people to take away is that there is hope, even though there is a lot of changes that happen in the brain and in the circuitry, the neurobiology of the brain, because of neuroplasticity. Because of the interventions that we have available to us, you are able to move forward and create new neural pathways in the brain that can help improve your brain's function and improve some of the structural changes that have happened over time. And again, it is a little bit challenging to think about that because I'm asking you to maybe shift your mindset. And I get this in clinic all the time. People say, if you're going to tell me to think positive, I don't want to hear you anymore. And I say, well, I'm going to ask you not to hear it that way. I think it's easy to hear it that way, that I'm saying, well, just think positive and you'll be fine. But that's actually not the point. The point is to really shift the focus. It's very easy to have an automatic thought when you're in pain, like, oh my God, I can't take this. Of course, that's automatic and that's normal. But then we have to make the effort to consciously produce a thought that's also going to create a new pathway in our brain that also becomes automatic, which is, this is very intense pain and I can manage it. I've done it before. So that's the kind of, I guess, shift that I mean in terms of the mindset. There's a lot of self-talk strategies that I have that we work on with folks. So I guess that's mostly everything I had to say. I hope that it can kind of make a little bit of sense, thinking about the dehumidification techniques for the chronic condition.
Perfect. And if any of you have questions, write them out, raise your hand. I want to start with the question that I'm sure is on a lot of people's minds. Having heard all this, Christina, where do I go for help? How do I find a PCP, a primary care psychologist, and are those services covered by insurance?
Thank you. That's a great question. So I'm lucky enough to be at the center, which allows us to embed psychologists in primary care. So anytime any patient comes in to see their primary care physician, they're there for a diabetes checkup, a checkup of hypertension or hyperlipidemia. If they're experiencing chronic pain, the primary care provider brings me right in. Those services are covered by most insurances these days. This model of care is becoming much more popular. You may want to ask at your primary care provider's office if you have a psychologist in primary care, and you might be surprised. Trying to think of a few different places around town. I know many of the UT Health clinics have embedded psychologists in primary care. I actually am part of the training program to help train psychologists in primary care. I know Communicare is one of the folks that is also trying to work on this particular model, but it hasn't spread completely. We're really working to try to enhance this idea. At the same time, many pain centers also have psychologists or counselors affiliated with their practice. And I always tell people, taking medication is absolutely important, but I think it's about 50% of the treatment. The other half is doing the therapy and the behavioral change in order to sustain your outcome.
Can we get a copy of your slides?
Yes, sir.
How do we do that?
Well, I think, so you can definitely email me, but I think we might have them as well, but I'd be happy to provide them.
Okay. We have a couple more questions.
Ron, all the presentations will be on our website. We're videotaping the whole.
Oh, perfect. So on the website, we'll give you that.
Oh, there you go.
Thank you, Dr. Blackwood. So this little camera here that you can't see is recording all of what we're doing. So you're on candid camera. What's the best way to encourage a chronic pain sufferer? That's a really good question. How do you make them feel better?
Did I hear survivor?
Yes, ma'am. Sorry, it's not sufferer.
Survivor, thank you.
Chronic pain survivor. Wow. Well, I, as a psychologist, I really believe that psychotherapy is a huge component. I'm biased to say that, of course, but I do think it's a key piece, not only because it helps one create a narrative for yourself and for your story, but it also can give you the tools that you might need to help if this is part of what you would like to do. I know many of the people I speak with say, I really want to get better because I want to help others. And that's typically a huge piece of somebody's mission. It doesn't have to be your mission, but if that is part of your narrative, usually in counseling or therapy, there are ways to think together about how to make that happen. There are many support groups. There are many what we call peer services. So people who have had the lived experience of chronic pain and surviving it. I often feel like those are our best resources for treating ongoing issues. So I would say counseling, psychotherapy, and finding that network for whom you could become a peer or role model for others is a great way to do that.
Thank you. And then one last question. Is there a difference between genuine positivity and toxic positivity?
That's a great question. And I guess kind of what I was referring to earlier, this comment that I get sometimes in clinic, is actually what I think patients fear, that I am telling them, in the face of all this adversity, I know you're really suffering, just think positive and you'll be fine. And that is kind of the idea of toxic positivity, this idea that we cannot recognize or acknowledge all the difficulty. And that is actually not the point of counseling or psychotherapy or CBT. The magic, I would say, of counseling and psychotherapy is that you are able to acknowledge, see, feel, and experience all of the negative and difficult adversity, and in the face of that, transcend, or I guess that's the hope, right? That you can transcend those circumstances by looking at the situation in a different way. If anybody's ever read Viktor Frankl's Man's Search for Meaning, I mean, Viktor Frankl, he's a Holocaust survivor, Man's Search for Meaning. That's really like the crux of it. I mean, he would never tell you, well, just think positive. I mean, he went through the Holocaust. But it's that sort of idea that you can transcend suffering that is beautiful and part of, our ability as humans. So that's kind of the power of it. So yes, there is toxic positivity.
Thank you very much, Dr. Aguilar. Appreciate it. And take your, you got it. I think that's your pen. Okay. We will be sending out a survey after the program for all of you to fill out, and we encourage you to do that. Also, let me take just a moment of personal privilege for Dr. Susan Blackwood. I want to invite Elena Gonzalez up to the podium, the Volunteer of the Year, and Dr. Blackwood has a few remarks and a presentation.
What you're going to appreciate later this morning or at noon is how much work this woman went to make sure you could have the right box lunch. And she went through laborious and very, very meaningful to us to have her do this work. We're a volunteer board. We have a volunteer advisory council, and she just stepped up out of the clear blue and said, I can do this for you. So thank you very much, and we really appreciate you.
And if you get the wrong lunch, we'll give you Elena's home address and phone number. Dr. Blackwood, before you walk off, stop for just a moment. Susan Blackwood, really working almost 24/7, put this event together. She was able to marshal the resources, find the space, put the program together, write the run of show, arrange for all of what you are seeing here today. She does it without wanting what I'm doing at this very moment, and I'll hear from her later. But please, a round of applause and a thank you to Dr. Susan Blackwood, who carries the heavy burden of still being a Nebraska football fan. Sorry about that, Susan. We have an annual bet. I root for the Ohio State University Buckeyes. Every year we bet lunch or dinner at a steakhouse, and the loser pays. And I'm looking forward to this year's dinner. Thank you, Susan. And now we're going to welcome Dr. Ellen Lynn up to the podium. Dr. Lynn has a presentation as Global Pain Association Medical Director, and she's going to share with you some thoughts as she comes up to do an introduction. Dr. Ellen Lynn, pain doc extraordinaire. And Dr. Mandua. Thank you. And do you have slides you're going to be doing?
Yeah, they're all.
I know, but do you know how to use this device? Green forwards it.
Okay.
That's all you need to know. Good luck. Thank you.
All right. So we got a couple of slides to go through, so I'll try to go as fast and as reasonable as I can. So we're going over kind of new technologies that's available out there for some of these new patients. So these technologies probably, some of them been out there for a while, and we're kind of giving like an updated talk. Some of them have been just out there for about 3 to 4 years. So the first one I wanted to go over is called spinal cord stimulation. So spinal cord stimulation is not new. It's been around for probably 10, maybe 15 years now. So the idea is that we can kind of block the pain at the spinal cord level. So the way we do that is that we can put electrical leads into the area of the spinal cord according to where your pain is, and then block the pain as it comes. So usually involves doing spinal cord stimulation for, these are some of the most common indications. So complex regional pain syndrome, which I'll go over that in a little bit, lumbar post-laminectomy syndrome, also known as failed back syndrome. Some of the new indications now are including a non-surgical refractory back pain. That means if you took your back pain, you went to a surgeon, the surgeon says, look, I know you have back pain, there's nothing I can help you with. And then another new indication would be painful diabetic neuropathy. So if you have really bad burning feet, sensation from the bottom of your foot, it's really hard to walk on, these could be a painful diabetic neuropathy. So what it usually involves is that you will usually get a 7-day trial of the device. So the device can be placed in using two hollow needles, and the electrical leads can be threaded all the way up to the spine level, and then the needle will come out. You'll have a little lead tunnel outside of your skin, connect to an outside battery. You do some of the normal activity, try it out for 7 days. At the end of the 7 days, we take out the leads, and you just have two little poke holes that seals in at 6 hours or so. And so if you get a lot of relief from it, then we would do the actual implant. So this is kind of one of the few procedures you can get a test run for it. So the implant involves putting in a battery as well as electrical leads. And again, we only do this if you get a lot of relief from it. So I kind of wanted to show some studies in terms of some of the new indications. So this one is for painful diabetic neuropathy. So you see two graphs, one graph on the left and one graph on the right. So the graph on the right, it would be CMM. So that stands for conventional medication management. So they took 200 people who have painful diabetic neuropathy, who has a hard time walking around. They randomized to a group that the endocrinologist would give them medication. So some of these medications you might be familiar with. So there would be gabapentin, pregabalin, duloxetine, some TCA, which includes amitriptyline. And then they also put a bunch of people in a different group. And that different group would be, they would do a trial of the spinal cord stimulator trial. And then if they get a lot of relief, they would get the implant. So if you look at the right graph, actually, let's look at the left graph. So the left side are the group who got the SCS, the spinal cord stimulation. So you can see that a lot of people started with 7 to 8 out of 10 pain, and then after the implant has been in, they dropped down to about 2.3. Obviously, it's not pain-free, but it's a lot more tolerable. People are able to walk further. People are able to go to the shopping mall without having to constantly worry about their pain. And that relief is sustained at 12 months. And that's with the 10 hertz high-frequency spinal cord stimulation, which for most people, it's paresthesia-free. So in the past where people had spinal cord stimulation, they get these kind of unwanted paresthesia, meaning when you bust that area, when you send a little electrical signals in the area, they get this buzzing sensation in the body part that they're trying to cover. So high frequency, so it's 10K hertz, it means that it's stimulating the area 10,000 times per second, which is not really perceptible by like human beings. So it basically kind of blocked the signal as a buzzing-free environment. So if you look at the graph on the right, so a lot of people started 7 to 8 out of 10 pain, and then after 6 months of medication treatment, you can see kind of some of them, on average, they actually stayed about the same. So at 6 months, they're allowed to cross over. That means people offer them spinal cord stimulation and see if they would take it. And about 80% of people jumped over. So you can see that consistently they're able to, after the implant, they're able to consistently get relief, and they only follow them up to 6 months for this study. So another one is for non-surgical back pain. Again, that's for people who you took your MRI to the surgeon, you tell them what does your back pain is, and they say, I can't help you. There's nothing I can see. So same thing, they would do a trial, and then the implant started about 7 to 8 out of 10 pain, and then they were able to reduce it to about 2 to 2.5 pain. But obviously, it's not for everybody. I would encourage you to consider the trial. If the trial's helpful, then do the implant. If the trial's not helpful, then that's something we say we tried, and that's something at least you try. So another option would be something called dorsal root ganglion. Dorsal root ganglion, it's similar concept. Essentially, you're parking the electrical leads at a slightly different area. So instead of parking the leads in a really wide area, you're parking the leads next to the dorsal root ganglion where the nerve root comes out. The effect is slightly different. So usually we would consider this for people more with complex regional pain syndrome, also known as, if it's some branch of that would be causalgia type 2. So what is that? So what that is that if you had some sort of ankle injury, if you have some sort of ankle brace or ankle surgery, after the injury is initially healed, for whatever reason, you still just have really persistently back pain in the extremity of the ankle that you have. So what commonly it's not common, but what can happen is that people can have these nerve healing, but it just somehow it's healed right and it's rewired wrong. So that when you're sensing light pressure, it sends your brain to a severe searing pain. So that can happen if just the nerve is not kind of healed right. And oftentimes it could be like in a wide area, as in touch one area of the foot, and there's this whole area, top of the foot, bottom of the foot, that can all sense pain at the same time. So that's kind of complex regional syndrome. So what scenario does that apply in? So you can have persistently foot pain after a foot ankle surgery or foot ankle fracture. Even if the casts sometimes are too tight for a couple of months, you can have that. You can have hip pain or knee pain after hip and knee replacement, testicular pain after vasectomy, and also growing pain after hernia surgery. So if you think about it, these are all areas that you can have some small amount of injuries to the nerve. But a lot of people do fine with it, but in some subset of people, that the nerve just never healed correctly. So the key for the dorsal root ganglion is that you have to have a small focal area, because it's not going to be able to cover the back and legs. You have to cover, like, it's a left groin, left foot, left leg, left hip. So it will be a small focal area. So the area where it stimulates is the area where it's pointing by the red arrow. So the nerve exits out onto the side. There's a little cell body. And so it's kind of where the nerve exits. So your nerves are usually mapped out in a dermatomal way, where usually like the C6 nerve goes to the hand, C7 nerve to the middle finger, and then L4 nerve goes to the inside of your leg. It's kind of mapped that way. So you can kind of see where your pain is and map it that way. So this is the difference between the dorsal root ganglion and spinal cord stimulation when you take an X-ray. So the dorsal root ganglion, you're putting the electrical leads on the left side of the graph. You can look at the electrical leads at where the nerve are exited on the side. The spinal cord stimulation, you're actually kind of parking the electrical leads kind of in the middle. So this is a study for dorsal root ganglion, comparing it to spinal cord stimulation. So for people with complex regional pain syndrome. So at about 12 months out, it's able to consistently show that it gets a better percentage of pain relief for more patients. So the next one I want to go over is called a MILD procedure for people with lumbar stenosis. So what MILD stands for is minimally invasive lumbar decompression, MILD. So lumbar stenosis, what is that? So that is a condition where if you have back pain, and basically it's caused by a compression at the central canal. So at birth, if you look at the picture on the left side, at birth, when you look down at a canal all the way from the top, what you should see is you should see a little circle. And inside the circle, there are nerve bundles. It travels all the way from the brain to your legs. And it should be a wide patent area. As you age, you'll have a kind of condition develop where either the disc pushes backwards, or if you have hypertrophy, which is growth of the soft tissue, that can impinge on the central canal, as demonstrated by the picture on the right. So as that happens, when you're standing up and when you're walking around, most people can have these symptoms called claudication. Claudication means that when you're standing up and when you're walking around, you just get this leg weakness, leg cramping after you stand up, and you're weak for a while. But if you were to sit forward and you hunch over and you rest, that would just create a few millimeter more of the canal that you're able to get that compression off, and you're able to walk a little bit more. It's very common. So if you think about, if you ever see people walking around, there's a sign called the shopping cart sign. Shopping cart sign is when people, when they go to H-E-B, they like to use the shopping cart because, well, when I'm pushing the shopping cart, it's actually, I'm kind of purposely hunching over a little bit. That gives a few millimeters space so that they're able to walk a little bit further. But when they're standing up straight, they're walking up straight, they just can't do it. They have to sit down after a couple of minutes, or after, I mean, if it's really bad, maybe after a minute or two. If it's not as bad, maybe 10, 30 minutes. And they can do that again, and when they sit down and they improve. And then the other one, this is something I came up with, is the rocking chair sign. The rocking chair sign is where, if you ever notice somebody who, when they get up from a chair, they got to kind of rock back and forth a couple of times, and then they come up. So what that is that their legs are kind of weak, they're compressed, they have to use kind of this momentum to kind of come up, and that could indicate lumbar stenosis. And usually when you get an MRI like this, you'll kind of see, they can see kind of the compression at a certain area. So what the mild procedure does is that if you look at the top picture, there's a purple area. So purple area in this case is your spinal cord, that's your nerve traveling down. So the green stuff is the kind of the soft tissue hypergrowth that it kind of compresses on the area. So what we do with the mild procedure is that we usually guide a straw-sized needle into the back, and so we'll use a little straw-sized instrument. So we can use insert a little instrument beyond the area and then kind of scrape some of the soft tissue out. So, and then you can restore kind of the spinal canal and have a little bit more space for the spinal cord. So, and then this is like a 3D diagram of what it would look like, because it should be like a little open space, and that those little white tissue are like hypertrophy tissues and hypertrophy soft tissues, and you can kind of grab some of the soft tissue and come out with it. So it's a straw-sized poke hole. So usually we just need to do 1 or 2 of those you can do that for 2 or 3 levels. So usually there's no incision. So that little poke hole will seal in about 6 to 12 hours. You can shower the next day. You can walk the same day. I actually encourage people to walk the next day. So when you have this, space that's narrow in the past, and you just create a little opening, it helps when you kind of wiggle the spinal cord and wiggle the nerve back and forth a little bit as you're walking, as you're moving. That will kind of create a little bit more space when there wasn't any space before. So this is the mild study. So a common procedure we offer to patients is an epidural steroid injection for lower back pain. So this is kind of the comparison for epidural steroid injection and mild procedure. So the y-axis, it measures the disability index. The lower it is, the better it is. So the mild is able to show that it's a little bit better for people with lumbar stenosis, with neurological claudication. Again, what that is that neurologically, if you stand up, you walk for a while, you get this cramping of your legs. Okay, and then the Intracept procedure for back pain. So this is more for back pain, which is due to a disc and vertebrogenic or disc complex. So what is the disc-related pain? So disc-related pain is where if the disc causes inflammation, or sometimes even the disc pushes out a little bit and causes some issue. What most people complain about discogenic pain is that they have no pain when they're moving around, but when they're sitting still or when they're standing still for a while, they just don't like that. They feel like they have to wiggle back and forth like a snake. So what it is that when you're stacking the bone and the disc on top of each other, it just exerts a lot of pressure on the disc that's injured. So they don't like to have the possibility of where all the discs are stacked up on each other and causing pressure under the disc. The other thing is that's disc compression. The other thing they have a hard time is that they have a hard time with a disc distraction, meaning pulling the disc apart. So what that is that if they were to reach down all the way to grab something from the floor, if they were to kind of reach down to tie their shoes, those would be disc distraction. They're kind of pulling the disc apart. So, but when they're leaning and when they're shifting weight, when they're walking, it's not as bad because they're constantly shifting. It's not so much weight on the disc by itself. So there's different gradients of how the disc degenerates. So again, the disc is the area between the two bones. There's a little cushion. It's used to absorb the shock when you sit down really fast. But over time, it can degenerate. So if you look at the picture all the way to the right, there's a little thin black cushion and there's a little white space in the middle. So that white area in the middle is hydration. It's a little bit fluid. So the right top corner, that's your type 1, that's your normal end plate, no issues. As you're looking down the picture, you can certainly tell that the most bottom picture on the right side, on the MRI, all the way to the right side bottom corner, you can tell it's no longer has that white thing in the middle. So you lose this hydration, which is the white signal. And then the other thing is you see these little jagged edges, so you can see kind of these disc degeneration. So on your MRI, this is not the actual MRI, but this is kind of a cartoon drawing diagram of the MRI. What you'll see is that you'll see a disc in the middle, but then you'll see something going on above and below the disc. Even if you don't know how to read an MRI, you can see, oh, I can pick out that disc looks kind of funky. It looks different than the other disc. So, depending on how you do the MRI, there's different retention signals that you can get. So usually modic type 1 is where initially you can have some inflammation, you have inflammation going in the area, and then after modic type 2 is just different nomenclature of characterizing how the disc changes over time. So with the Intrastep procedure is that we can, so the nerves to the disc actually travels within the vertebral body, which is the bony area. So what we can do is we can put a kind of a straw-sized cannula into the middle of the bone, and we can heat up the middle of the bone area to deactivate the disc pain. So usually if you have one disc, we would go to the disc above and below the area. Again, it's also pretty small poke holes. Same thing, it's probably a little bit smaller than the diameter of a drinking straw. But usually it would be 2 poke holes if you have one disc that's having issues. So it would go above and below that disc. Again, this is what it looks like on x-ray. So all these procedures are done with like fluoro live x-ray guidance. So usually we would put the needle in and then see where it is and then move the needle in a little bit more. So it's kind of pretty slow fluoro guidance for these procedures. And then same thing, no incisions, light activity. You might be a little bit sore because I do have to go through the bony area for about 3 to 5 days. You can walk the same days. You can resume activity, like almost normal activity, 5 days after. The relief for the Intrastep usually doesn't come right away. So usually it takes a couple of months. What my hypothesis, so this is kind of the 5-year study research that they had done. They took people who have about 6 to 7 out of 10 pain, and they follow them for 5 years out after the Intrastep procedure. So they usually start about 6.7 out of 10 type of pain. So this is at the first measurement, which is 3 months after the Intrastep procedure. It went down by about a half or so. And then it continues to improve even at 5 years out. And sometimes patients ask me, how does it improve from a procedure done 5 years ago? So I think one of the things that when you have like discogenic pain, you're so embodied, you're so intertwined with pain that you just don't want to move. So that when you no longer have that pain, people are actually able to do more, people are able to walk more, and you have all these other little areas that can cause the pain that actually improve because of that. So rarely do I have people who come in who just say, oh, I have a disc-only pain. Usually they have a disc pain, they have some muscle pain, they have some little bit of arthritis pain. But usually the whole goal is that as they're able to move more after these procedures, that they're able to kind of relax some of the pain related to the muscle, relax some of the pain related to arthritis. Okay. So with that, I'm going to pass it to Dr. Ellen Lin for the next part.
Okay, so I have to go fast because 5 minutes, Ron's telling me 5 minutes. I have 3 more, I would consider microsurgeries. We're so excited to bring all these things into the pain world. So the next thing is peripheral nerve stimulation. So these are indicated mostly for joint pain. So in the past, you might have to get like knee steroid injections or Symposium injections and all these things. And now we can actually put small little electrical chips, computer chips, like a stimulator in the back, but now it's right next to the joint. So you can decrease the pain in the patient. So maybe they can prolong and pass down and kick the bucket, down the road, so you don't have to have a knee replacement so soon, especially for the younger folks, right? And so we put the wires next to the knees, the nerves around the knees, and also to the shoulders most commonly, as well as hips, and even some SI joint we can manage. And then actually I'm chaptering a textbook a chapter in the textbook for ankles. So you can put these little computer chips through a needle microscopically and even implanted in the ankles for ankle pain. So it's mostly for joint pain or non-surgical joint pain. And so that's sponsored by StimWaves. They have the technology to be able to do that. So the battery is actually external, so we don't implant it. We have small, tiny little incisions, poke holes almost, that we can implant these devices. And again, most people will go through a trial phase, about 5 days or something like that, in order to get 70, 80% pain relief before we do the real surgery. This is what it looks like. The battery is kind of sterilely put right next to the tiny little wires, and we implant these little wires right next to the knee, ankles, elbows, whatever. That's it. And the wearable devices, depending on where you're implanting these devices, you gotta be able to kind of put the patient to comfort, right? So if it's around the knee, it looks like a little knee brace. So this tiny little battery that looks like a pager, or old doctor's pager, and can be worn right around the knees or the ankles or at the shoulders. And I've been doing recently quite a bit of bilateral shoulder pain in patients who are using their wheelchairs and their shoulders are completely shot, and they may not be healthy enough to get shoulder replacement surgeries, and that's really the only option they have. So we're putting 2 wires, one on each shoulder, and they just wear men would put the battery in their pocket, and women would put it in the bra. That's pretty simple. Next thing is, in the past, when we have tendonitis, right, hip tendonitis, get that a lot. People starting to limp around, and then their tendon gets calcified, or the bursitis, the hip bursitis gets calcified or tender and inflamed. So in the past, we were putting steroid injections in the bursitis to kind of alleviate the pain. But guess what? Most of these patients have other issues that they were getting steroid injections in back and shoulder and whatnot. And with the increase of steroid use, you have the risk of osteoporosis and side effect of obesity and blood sugar, elevation and all that. So TenJet was created actually as a debridement device. So it's through a tiny little needle. So what it does is through the Venturi effect, it debrides the tissue in the past for wound care. But they redesigned it, and now you're debriding basically dead chronic tendons and dead chronic bursas in the hips or elbows, tennis elbow. And I've actually done a few plantar fasciitis type of, patients, and these are recovered. Patients are recovering really, really well with this. It's almost, especially the hip bursitis patients will tell me, Dr. Lin, it's really weird. I'm literally 2 hours, I got home from the surgery center and I can climb up the stairs without problem. In the past, if I put my hips up and I step up the stairs, my hip really hurts. And so, and the incision is really not an incision, it's really a poke hole through that tiny little needle right there. We debride it, and when the debridement comes out, it's like saline that blasts through, and then I call it the vacuum for my patients. It would vacuum out the dead tissues or the dead bursa or the dead tendons, and then the new tendons can grow in, right? Then you can strengthen it later, and the pain is gone, and you can get healthy tissue to grow in after that. So that's what it looks like. We do the procedure under ultrasound, so you can see the densities under the ultrasound, and you go into target, and the saline gets pressurized through their patented technology, and it goes to the needle, and then the other part of the needle vacuum the junk back out. Yeah. So again, you can assume regular activities pretty much on the same day. Except, you're lightly sedated. You're under twilight when you're getting these things done in the surgery centers. I tell them not to do anything heavy for about 2 weeks, but most people are eager to go back to what they were doing, especially the golfers. It's a real addiction, but in a good way, right? They're like, when can I do? What can I do? I was like, please, 2 weeks. It's 2 weeks, okay? Because you don't want to bleed in there. And then, so the last thing that I'm going to talk about, so this is all like microsurgeries that your cool pain doctors can do, right? All of these things that we talked about. But now it's not just the microsurgeries through a needle, and this is actually not just to reduce pain. ViaDisc is actually a graft. I want to call it stem cell, but it's not really stem cells. It's actually harvested from the disc material is harvested by these wonderful scientists from healthy, donors, almost like cornea, right? So you're getting healthy cornea from a, deceased patient. You're getting ViaDisc from healthy nucleus. The nucleus is the jelly material that's inside your disc, right, that cushions it. So as we age, like Dr. Lowell talked about earlier, right, you have these modic changes. Basically, your disc is getting inflamed because of overuse, and it's disintegrating and drying up, right? And this material can get injected through a small little needle into the non-healthy disc or drying up disc and create that space and potentially not just, definitely the study shows that it reduces pain for sure, but it actually regenerates. This is like the age of regeneration, regenerative medicine. It's very exciting. Dr. Stein is going to talk about a little bit more about like stem cells and stuff like that later on, but this is the next step. So same thing. The disc pain is aggravated usually by sitting. So these patients, they say, "Doc, I just can't sit too long," right? I'm looking at some of the audience. I was like, "Man, I wish I had this 8 years ago. I wouldn't have put a stimulator in you, but wouldn't have this choice before." But now that we have it, when they're sitting too long, they hurt, and then when they stand up, they feel better. Or if you bend over brushing your teeth, it kind of hurts. That's discogenic pain. The pain is coming from the disc. And remember that slide, the modic changes that Dr. Luo showed you earlier, that's what that looks like, kind of dried up. It's kind of gray looking. It's not white, that beautiful disc that's healthy. The black ones it's just unhealthy. So they did a 12-month study that proving that this procedure works. So they followed the patients, and 200 patients. That's a lot of patients. It's randomized, controlled, and you got one group that got saline, the other group got ViaDisc, and it made a huge difference. It's about 76% of the patient really got reduction in pain. I mean, in my eyes, that's actually better than back surgery, right? For sure, because they don't have a 76% success rate compared to this. That's minimally invasive, right? It's through a needle. Again, you can walk on the same day. I just tell the patients for about for the super athletes. Again, I'm going to pick on the golfers. They want to go back doing this because they feel better. Probably up 2 weeks afterwards. I say 6 weeks in total. Probably 6 or 8 weeks is probably the best thing to not to aggravate the disc. Let the disc grow into the adjacent bones and the annulus, which is the wrapping on the outside of the disc. Okay, and avoid lifting. So.
Thank you. All right. We even got a whistle. That's good. Thanks. Have a couple minutes for questions, if anybody has a question. There's a microphone in the back if you want to use that. Not loud enough.
Oh, okay. I can repeat the question. So the question was, there was one of the slides that says ESI versus MILD. So ESI stands for epidural steroid injection, and MILD stands for minimally invasive lumbar decompression. So epidural steroid injection is something we commonly do for patients where we use a needle to guide numbing medication and steroid in the back. The goal is to decrease some of the nerve inflammation around the spinal cord level. So in some people, it's very helpful in terms of like if the disc acutely pushes out, causes a lot of chemical inflammation. Sometimes when it's a structural issue, like if it's a physical compression, sometimes people just tells me, yeah, the epidural helps. Like I get 100% pain relief for 3 days. And so that's when I know sometimes it's like a lot of physical compression onto the nerve, and that sometimes doesn't help as much for lumbar stenosis.
If you want to write out a question, we can pick those up. TenJet. Is it helpful with hip bursitis?
Yes.
That's a question we love. peripheral neurostimulation for lower back pain.
Yes, it does. That there are some nerves in the back called the cluneal nerves, especially that wrap around like hip pain. That can be controlled by stim wave. And also the peripheral nerve stimulation, the same little wires can also be placed into the lumbar or cervical spine in the spinal canal that controls different sort of spinal pain that Dr. Luo described. But it's the battery, since it's not implanted in the body, if you have evening or night pain, it's probably not a good indicator, to use that device.
Cool. Is the dye for MRIs, are there other options if a patient is allergic to the dye?
I guess it depends on the type of procedure you're talking about.
Doesn't say.
Dye for the MRIs.
We don't.
We usually don't do use dye for the trial or the implants. I'm not sure if that's what the question was.
The question was, one of the slides showed that y'all use a contrast dye for the MRI. No?
Usually the MRIs, unless you have certain indications, usually the MRIs are not done with contrast. Most of the time they're non-contrasted, but it has, the MRI by itself will contrast different materials, like bone will show up as a color, and then disc will show up a color, and spinal cord nerve will show up as a different color. Yeah. Oh, okay.
Are most of these treatments superior to RFA?
So RFA stands for radio frequency ablation, where you cauterize with a needle little nerves around the back to reduce a mechanical pain, like arthritis pain, right? So most of these treatments are probably past that RFA stage because the patients have failed RFA, or if they've done it for so many years that the nerves kind of got mangled up and you can't burn that much anymore on these arthritis pain. So yes, from Dr. Luo's lecture, you could see that Nevro, the high frequency stimulation, actually can decrease the axial back pain, meaning just back pain, which is very hard to control, and it's very difficult, especially even with back surgery, laminectomy and discectomy, they still continue to have axial low back pain. That's controlled by high frequency stimulation leads.
Cool. And Dr. Lin, thank you. Appreciate it. Thank you very much. I'm sorry? Yeah, we don't have time to get to them all. If your question didn't get asked, see if you can nail Dr. Lin or Dr. Liu here during a break. And now we have on the next guest speaker, our presenter, Dr. Marianne Pinkston, pardon me. She's a GPA board member, hosts a radio show on KLUP Radio. You can find her on YouTube as well. And she is an incredibly talented, knowledgeable physician who cares about her patients. I know that because I've let her stick needles in me. Please welcome Dr. Marianne Pinkston.
Thank you, Ron, and I did that extra painful just because you're Ron, and that's it. But no, thank you guys. I have some patients here, I have some friends here, I have my kids here, and I'm also thankful that you guys are here today. And thank you, Dr. Blackwood, for all you do, and for this enormity. This is wonderful. I'm so glad that we're past COVID and getting back to this. So I want to visit, Ron, is that the advance?
Hit the green button.
Okay. All right, good. And so, I wanted to talk about something fairly practical. I mean, I've got a lot of different topics that I can go over, but I wanted to talk about something fairly practical to people, things that people ask me all the time, and that is about natural pain relief, natural supplements and things like that for sleep and for pain. You guys must know how important you are that I am here today, because I am going to miss a very important football game with Texas Tech and UT. So that is, I'm not going to pick on anybody today, but you're important today. So I'm just teasing. So in that, I do have a radio show and program podcast that I do, and I go over a lot of these different topics. So I also will have my slides today on my website. It's actually there now, and that's DRPBetterLife.com. mylife.com. So please, I would love to share information with you. And so let's get started. When it comes to pain, there are so many different types of pain. Each and every one of you here have a very different type of pain. So it's hard to get all of these pain issues into one talk, especially a short talk like this. So I just wanted to highlight a few things that some people are inflammatory. Some people have neurological or neuropathic pain. Sometimes it's a structural pain like osteoarthritis, bone on bone rubbing together. Sometimes it's just muscular, that is a lot of muscle spasm. That can be very painful. But most of the time, it's all of these put together. So it's hard to isolate any one of them. And if any of you know me really well, I love the thought here that motion is lotion. I'm a big exercise advocate. You'll hear during my pain talk why. So I won't go into it yet, but I am a big advocate on exercise. So that is top of the list. And I'm going to do that. Okay. So just a few ideas about each one of them. Most of the time, something inflammatory is either autoimmune, where your body is attacking itself. Gout, there are a lot of people who have gout, which is a uric acid, and it inflames the inner it gets into the joint and inflames the joint. Things like rheumatoid arthritis, which is what I have, tendonitis, infections, things like that. You'll notice that this type of pain is usually red and hot and swollen and very, very tender. A lot of people would use over-the-counter anti-inflammatories, or what we call NSAIDs, the non-steroidals. Things like ibuprofen, naproxen, and all of those things. They can be very hard on the stomach and hard on the kidneys, which is something I learned very early in the game with my pain. Steroids, too, another wonderful thing from time to time. That is a lifesaver for me, but again, you have to watch and be very careful about overuse of them. Another lesson that I learned very hard early in life, or several years ago. But the things that I think help inflammatory type of pain can be dietary. So just the things that you are putting in your body from a diet aspect, what you're eating, what your lifestyle is. So you have to eliminate some of these foods. Things like gluten and dairy can be very aggravating to joint pain and things like arthritis and autoimmune diseases. Nightshades are things like tomatoes, mushrooms, things like that. But sugar is a huge one. And I am not talking about carbohydrates. Carbohydrates are okay. But sugar in itself, the processed, is something that generally is not okay. So the more natural things for inflammation are things you're probably fairly familiar with, but curcumin, which is also turmeric, and is a great anti-inflammatory. It does matter what type you use. But fish oil is wonderfully anti-inflammatory. You have to take fairly high dosages of it, so 1 or 2 might not do it. You might have to take 3 or 4. Just be careful, thin your blood a little bit. Remember, ask your doctor if all these things are okay. SAMe and vitamin D is one of my favorites. Vitamin D cures everything. And so from weight problems to depression to sleep to, your bones and aging and pain. Cat's claw is a great antiviral. So if you suffer from shingles or some sort of infectious type of pain, cat's claw is a great either antibacterial or antiviral. CBD, that's a hot topic and something that would take 2 or 3 of these symposiums to cover completely. But CBD is not a drug. It is not a drug. THC is considered a drug, but there are lots of CBDs that do not have THC. It is not a drug. It's very safe for you to use, is very effective, and something I use all the time and prescribe. For people with gout, the tart cherry extract can be very good. They come in little juices you can buy on Amazon. And then glutamine. Glutamine is something that is anti-inflammatory. I know when I go work out and I wake up sore the next day, if I can just take a lot of glutamine, usually about 4,000, 5,000, 6,000 milligrams, that soreness will go away. And it would be great if I would take it, right after I work out. That would probably be smarter. That doesn't always happen. Smart is not always on my list. Neurological neuropathy. So this is a big one. I have this too, and it is where there has been some sort of trauma to the small nerve fibers. So mostly it's in your feet and hands. You feel that burning and stinging at night. It itches. Some people will describe it as creepy crawlies, but it can be extremely painful, and not so much really pain, but it can just work on your last nerve, no pun intended. It is very, very difficult to deal with. And so most of those things come from the effects and death on small nerve fibers. So things like diabetes, which the high sugars will kill those nerve fibers, cholesterol disease, artery disease can do it. Alcohol is a very, very important cause of it because it eliminates a lot of people who have a lot of alcohol in their, I guess in their diet, when they drink a lot of alcohol, tend to be very deficient in a lot of vitamins, especially a lot of the B vitamins. That can be a cause of neuropathy too. So I included that as a cause. Toxicity, so if you've had chemotherapy in your past, that kills those small nerve fibers. Certain metals or pesticides, things in the environment, water, things like that, that you might have been exposed to maybe in some place where you worked for a long period of time. And in medications can too. That's how mine got started, was medications and problems with B vitamins. And then infection, things like herpes and shingles, even HIV can do that. But it is very, very intense. It mostly happens at night. And sometimes just keeping the covers on your limbs or having socks on will, make it a lot worse. And so, what we try to do therapy-wise is stabilize the nerve, because it's either dying and just throwing out all of its, effects and crying for help, basically. So what you want to do is just stabilize the nerve. There are some great prescriptions that do this, but a lot of these prescriptions can cause a lot of side effects. They can make you very sleepy, hard to wake up and drive and do the things that you've got to do, and you got to get up and go to work. But gabapentin, Lyrica, those medications, antidepressants, things like that do work. Lidocaine is a numbing medication. This is something that works very well for me when I have a sciatic problem. I had a lidocaine patch. Lidoderm or ZT Lido or creams and topicals, and that helps me when I get in the car to drive a long distance. I'll slap one of those things on, and it's aces. It works beautifully. But the thing that a lot of patients will look for in the past, not so much now, would be narcotic medications. And narcotics do not typically work for nerve pain. And so even the anti-inflammatories, ibuprofens, things like that typically don't work. And so what I try to do is get to the source of it, and if it's a B vitamin deficiency, well then we give you the appropriate types of B vitamins. The problem with B vitamins, if you guys, go out and say, well, I'm low on my B, I'm going to go out, you'll buy a B12. Not knowing there are 8 B vitamins that are very important. So thiamine, folic acid, there's many of them. So you have to get a super B complex, and that is where you get all of the B vitamins there. And alpha lipoic acid is another good supplement. This rarely has any side effects, really makes you sleepy. But at a good dosage, 1,200 milligrams a day is very effective. Again, CBD. CBD is going in every slide that I have, so just count on CBD being there. It is a nerve stabilizer. Things like carnitine, and then magnesium is absolutely one of my favorites. Magnesium helps a lot of different pains. It's included, again, on the list of most of my slides. And then the phosphatidyl groups. This is something that most people really don't hear, most doctors don't recommend. This is something that has helped me so much over the years with the neuropathy, and it's phosphatidylserine, a phosphatidylcholine. There's a third one that's not very readily available. Usually in combinations, it can be a little bit expensive, but that combined with B vitamins is great for neuropathy and very easy to buy and use. And of course, there are things like acupuncture and physical therapy and stretches. And then guess what? Exercise, another one that I really think is very helpful, helps to stabilize the nerve and get more blood flow to it. On the structural side of things, it's bone on bone. So osteoarthritis is the biggest one. Rheumatoid, eventually it starts as inflammatory and then becomes bone on bone. And then, it's just generally overuse of these joints and compression, maybe disc compression, like Dr. Lynn, Dr. Lou were talking about. Carpal tunnels, things like that, where the nerve is being compressed. A lot of times that can be handled by procedures. So the things that Dr. Lynn, Dr. Lou are talking about are excellent. You guys, so many people are so afraid of, the stimulators, and it's saved so many lives. I've seen so many people helped by them. So don't be afraid, and especially with these guys helping you, Dr. Lynn, Dr. Lou, they are amazing doctors. And so then you get down to, some of the injections that you get in the joints. So you got steroids, you got rooster comb, you got hyaluronic acid. All of those things are okay. They're very temporary, though. So it'll work one time, it won't work the next. And then steroids, the science is kind of mixed, but steroids can do some damage over time. But these are very temporary. Insurances don't like them, and they will typically be expensive and difficult to get over and over. Again, I'm always big on getting up and stretching and moving the body. So PT, chiropractic, acupuncture and things like that, yoga, exercise. All those things are great, especially when you have a guide. I've had a trainer for almost 3 years now, Sonia Romish. She's here in town. She is amazing and has helped me with nutrition and exercise. You'll hear about these things in a minute, but get somebody to show you and help you with that. You can do it. Some of the things that you can use supplement-wise. So glucosamine chondroitin has been around forever, and it has so many studies. Really very helpful, but it does matter the brand that you get. I typically will tell people to do the Kirkland brand. Kirkland has, most of the time a very, very good set of vitamins that they recommend. It's not always perfect, but I think the glucosamine and chondroitin, that's one of the best ones. Again, a turmeric or curcumin and fish oil, all of those help to stabilize and give a more, fluid to the joint. Collagen. So collagen is a really big one lately, and it's been around a very long time though, and has some great studies to it. And I've got one in the basket for your door prize today, a very good one. And there are different types of them, and all of them have some studies behind them. Just get one that has a good mix of either 1 and 3 or 2 and 3, but it just doesn't really matter which one. But a good mix of them is very helpful. Glutamine, that shows up again, is always great as an anti-inflammatory, and CBD, of course. Things like MSM is usually in with other products. So you'll see a mix of glucosamine, chondroitin, and MSM will be with it. Also very good for your mood and sleep as well. And then always, getting plenty of hydration to your body. Your body needs water to hydrate its joints and keep things lubricated. Spasm is a spasm. It is usually from a nerve compression or not being stretched out enough, but sometimes muscle spasm can be worse than, herniated disc pain and discogenic pain itself. I see more of issues from patients having muscle spasm, and the pinched nerves, herniated disc, or overuse of the muscles, stress, some traumatic event. Things like TENS units and trigger point injections are very helpful. The injections can be temporary. You still have to work on the spasm. When your muscles are spasm, they have memory, and they remember that they like to be spasm. I wish they would remember being unspasm like that instead. But they remember that. So when you go through a process of physical therapy or chiropractic work or whatever, exercise, you basically have to work for several weeks and several sessions to retrain those muscles to relearn how to relax. And they'll do it, but that's why you can't just go one time. You have to keep doing it over and over. And then after you leave physical therapy, you have to keep going, or maybe not keep going, but you have to keep doing those exercises and stretches that they give you to maintain that. That is the key to it. Otherwise, it'll work for a little while, and then it won't work anymore. Muscle relaxers, I really think truly are brain relaxers. I think they might help, and it's okay if you have some. You might be able to sleep a little bit better at night, just something to kind of knock you out in a way. but that is not going to get to the underlying muscle and help it to relax more. You do have to stretch those guys out, and you do have to take some of the more supplement-based types of therapies like magnesium glycinate. So magnesium is interesting because you sometimes absorb it, sometimes you don't. And that is based on the little salt that is to it. So when you see magnesium, you will see magnesium glycinate, magnesium citrate, magnesium combined with something else. So the ones that you don't absorb, that has the salt you don't absorb, you have diarrhea. So it's good if you're constipated and you need a laxative. Well, magnesium's going to do it for you. But if you're trying to treat muscle spasm, please don't take one of those. You're trying to do the opposite. You're trying to get the magnesium to actually absorb. And magnesium, there's other ones, but magnesium glycinate is very, very great at that. A lot of people go to bed at night and they tell me they have leg cramps at night, in their feet will twist and turn, or hands or something. Most often that is magnesium related. We all have magnesium deficiencies. So if you go to your doctor and you get your labs checked and you get your magnesium checked and they say, oh, it's normal, it has to be normal. Magnesium is needed to keep your heart going, or else you die. So your body will, if it's deficient, it will steal from the muscles and the tissues and bones in order to keep your levels normal. Well, when it steals from the muscles and tissues, guess what? You're going to start cramping because it's telling you it needs more. But your blood levels are going to be normal. So that's a big important key to magnesium. So again, magnesium is great. It absorbs through the skin very easily. That's why Epsom salt baths and things like that work. You just have to get a good dosage of it. And some of the creams and stuff are fantastic, very inexpensive. And so as... What do you need? It's not changing on me. Am I doing the right one? Yeah, okay. It was the wrong green button. There's two green buttons. All right, so there's two green. You didn't tell me there were two green buttons. So it's always Ron's fault. So as far as sleep then, sleep is always very, very important for getting your body to behave and act the way it's supposed to behave. It's important for helping with, pain disorders and depression and things like that. So never underestimate it. Don't take a sleep aid, either over the counter or any of your prescriptions that are given. The reason you don't want to do that is because you need deep stages of sleep in order for your body to heal and repair itself. So if you are taking something like, Ambien, Lunesta, or even, ZQL, things like that, your body will not go into the deeper stages of sleep. Therefore, it has very little time to actually repair itself. You may be asleep for 8 hours, but guys, it's hypnotic sleep. So it's like, alcohol does the same thing. If people take, toddy or something before they go to bed at night to induce sleep, you will stay in a hypnotic light stage of sleep the entire night. Your body will never sleep truly and repair itself. And when you don't sleep and you don't fix cortisol or stress hormone or help your adrenal glands fix itself, then you are going to become more inflamed and in more pain, and your body is not going to function well. So treating your adrenal glands and stress hormone by getting very, very good deep stages of sleep is probably one of the most important things you can do for either weight loss, which helps chronic pain, for the repair of your body systems, muscle repair and things like that. And when people are under tremendous stress, eventually they become melatonin resistant. So melatonin no longer works for you to get you to sleep. So you need a very, very good adrenal supplement. And the adrenals, ashwagandha, relora, licorice root, there are a whole lot of them, adrenal extracts. There are so many of them. There's some CBDs that contain them. There are a lot of ways to treat your stress. And when you do that, then your body starts to return to melatonin again and listen to it and help you rest again. That's the key to getting your sleep turned around. Melatonin, when people use it, they'll start with a milligram or two. If that doesn't work, they'll take 4 and 6 and whatnot. Melatonin works the opposite. The more you take, the more it's a vitamin and anti-inflammatory. You take less. So if 2 milligrams doesn't work, take 1, take a half. That's the way to trigger melatonin to work better for you. And so, again, try to stay away from some of the over-the-counters as well. Every once in a while, you have to get a good night's sleep, do it. It's okay. You have to sometimes. But I think staying away from those and getting good sleep is the most important part. And so, all right, I had Darren Maslek, who is a great photographer, took some photos of me this year finally. I haven't had any good headshots ever, I don't think. But that is the podcast. That is the QR code. You can scan it. Please do. Scan it right now and jump on. When you get to the website, it will take you to the YouTube and all of that, where you can, or all the platforms. Again, I am on radio, but guys, thank you. It's a whole lot. In fact, my table, I was a little bit late, so if you didn't get your passport signed, we'll be over there to sign it for you, and I've got some goodie bags too. But again, guys, thank you so much. I know you have questions, so let me have them.
Anybody have a question? I have one. Go ahead. You have a question? Can you write it out and we'll pick it up?
Yeah, just the dosage on fish oil.
So,
Question is fish oil, good or bad?
yeah, it's good, but the dosage. So fish oil generally has two pieces to it, as DHA and EPA. And so EPA is really good for cardiovascular anti-inflammatory issues, and DHA is really good for more neurological, brain issues, whatnot. But the combination also is very, very important. So don't worry about that so much. It's just kind of a tidbit in case you're looking for dementia or something. DHA is good or whatnot. But if you could take about 4,000 to 6,000 milligrams a day, that is generally the best dose.
Or eat more salmon. You can get it right on the hoof that way. Algae oil, is it as good as fish oil? And what do you think about kinesio tape?
So, this is probably a great question, or maybe Dr. Lynn, Dr. Lou, but the kinesio tape is okay. I think these are all things that are very supportive to muscle and tendon problems and whatnot. So, you've seen the football players that have the piece of tape, or, volleyball players and whatnot, they have the tape over, their tendinitises and joint areas and whatnot. So that always, there's a lot of great things that can help support, and I think that mostly gets them through their games or whatnot, so they don't have so much, pain, but it doesn't cure anything as far as I'm concerned. Somebody can correct me on that. That's always fine. But the kinesio tape is, again, just something supportive, which you can use. And then algae oil. So algae oil is, when you're looking at, again, you want to get through EPA and DHA. And I'm not sure what the balances are on that. I don't use that quite as much. And so I pretty well stay with simple fish oil. If you're allergic to fish, though, I don't know if there's an allergic component to that as well. It shouldn't be. Algae are different from fish. But if you can stay more with the fish component or from a food source, that is what I usually have people do. Algae may also have a little bit of iodine to it, which can support thyroid and things like that. But again, dosage-wise, I'm not sure. I don't use it as much, so I'm not as familiar with it.
Got a couple more questions, and then we're going to give you an opportunity to walk around a little bit. How do you know if you are vitamin B deficient? And if my doctor doesn't do anything about it, should I ask?
Sure. Isn't that an amazing statement? If my doctor won't, check it or do anything about it, I don't get that, but those are things I do check. I think the problem is, though, that you generally, if your doctor's checking it, they're checking mostly B12. And they don't, realize that folic acid, thiamine, and all those others, niacin, and everything else, all of those 8 are just as important. I'll just tell you right now, you can guarantee you're B deficient. You don't have to check it. You are. Our food sources and our soil is leached now. We just don't have as much in our diet as we used to. So everybody I check, and I do check it, everybody at my clinic is deficient. So you can just bet on it. And honestly, I think it would be very, very difficult to overdose on it. If your body makes too much, that's not good, but it's very, very difficult to take too much.
What do you think of cupping?
Oh, wow.
And then explain what it is.
Okay, so you've seen people, I guess, who go to either a masseuse or an acupuncturist or somebody who does alternative therapies, and then they come out with the little circle bruises, and that's cupping. And so I don't know, Scott is here, Scott Taylor's here. You can probably speak to it more than I can. I've never had it done, so I'm not sure. But I think, again, all these alternative therapies are very, very good for helping, to draw out toxins and, get your muscles to relax and do help for neurologic pain and all. So I'm for it. It's not an avenue that I'm a specialist in, so I'm not sure. But I think that all of these alternative therapies, there's never just one thing that works. So you have to take a little bit from the pile and do a lot of different things in order to put it together. And your recipe is different from my recipe. What I need is very different from what you need. So you just have to take, this supplement, do this therapy and this anti-inflammatory and this medicine or not, and put your recipe together as far as what works for you. And cupping can be a part of that.
We're going to get a chance to ask Dr. Pinkston some more questions later because she's coming back after our lunch. I want to do something now. Take a look at Dr. Pinkston. Stand over here where they can see you, please. Okay. Close your eyes for a moment and imagine her weighing 162 pounds more than the woman you see here. We'll catch you after lunch. Thank you, Dr. Pinkston. Now, what we'd like to do is give you some time to visit our sponsors, our vendors, get your passport initialed, and for every 4 initials you have on there, you get a door prize ticket. The more tickets you have, obviously the better. We're going to have lunches delivered by our volunteers at your table at 12:10, and then our volunteers from ACOG will bring you the lunch. The colored dot on your name tag indicates the lunch variety that you ordered. And so we will see you in just a little bit. Walk around, feel free to use the facilities, and be sure to get those passports initialed. Thank you.